everyone. Now I'm to present my individual oral assessment. So the background, introduction, the identity and situation is a 37 years old female. She's 12 hours post-op laparotomy. They find out some parts full of the four quadrants, so down the washout, and an unknown drug allergies. Past medical history is last hospital admission about 4 days ago. Complaint about abdominal pain. Goal of the care plan is all active. And also he got a COVID about 10 days ago before this admission. And rat test negative but PCR positive. Also she's have hyperthyroidism, depression, chronic back pain, and she's not a smoker. Social and family history, lives with a husband, full-time worker in the factory, has a daughter and a son. About the assessment, always come through the ABCDE. So I done the airways pattern, self-ventilating on airway. She's not really speaking full sentences, but like short words. Respiratory assessment, I'll be focused on look, listen, and feel. And then go to the physical assessment for 4 major approaches: inspection, palpation, percussion, and auscultation. Inspection, so airway pattern, working or breath is increasing. Respiratory rate is 35, oxygen saturation is about only 90. ETCO2 monitoring on the phone monitor is 36. Speaking short sentences. Neurological wise, GCS I'll give her a 14 out of 15. So E about 3, not 4. V is 6, V is 5, and 6. So she's alert orientated. Presenting fatigue, dozing on and off. RAS number is -1 to 0. Central, the lips and body and peripheral limbs color opaque, not diagnosed. Chest abnormalities, diabetes, shape is neo-sunken, neo-trauma, neo-injuries about the chest area. Bone framework, rib cage, straight spinal processes. Symmetry, bilateral symmetry. Characteristics of breathing, rate is fast, about 35, rhythm and deep breath he's taking. Palpation of the chest area, the trachea and anterior posterior thorax. So I didn't detect any skin or structural abnormalities. Trachea position is the midline, is not deviating. Thorax assessment, skin temperature and texture is warm to touch but not too warm. I'll say give it normal. Scapular and surrounding muscle is all symmetry. Chest to wall excursion is expanding when he's breathing. Percussion is trying to identify any boundaries of the lung field and the density of underlying structures. Normal lung sound has a resonant sound, so for her it's all normal. Auscultation, so I'm looking for some diminished or absent breath sound, but all air edge is clear. So whenever she's breathing in, take a deep breath in. When I ask her, I can hear the breath sound in. So neo-stridal, neo-wheeze. Key findings about assessment is both sides of the lower base is decreased for air entry. It's not quiet yet, but I can't hear as much as air entry when she take a deep breath as the mid and upper lobes. Saturation is starting to decrease, and then breathing is more shallower. So I'm just query, probably there's some time when she taking deep breath. So I asked the patient, like, when you take a deep breath, do you feel like pain there? She's kind of like denying. She says she's always like about the same pain, but the pain number. And then she's also on the metronome to support the blood pressure. It's running at 5 mils per hour, still 5. So it's metronome 40 milligram in 20 milligram in 40 mils on the stringent drive. Meanwhile, she's complaining she's feeling about nausea and vomiting. So the management and priority is, I was thinking of change her from nasoprone to high flow nasoprone with the NIV, non-invasive ventilating. Also, I need to get a doctor to probably order a chest X-ray, because the last time she having the chest X-ray was she was in ED. Pain management as well. I have checked a look of the pain PRI medication. She does have tramadol, 50 to 100 milligram for IV push. and buprenorphine sublingual, and also check the previous use. So previous use more than 4 hours ago. PI antibiotics that she has ondansetron, Maxilin to be used. So I always go through the ABCDE. So my priority will be airway first. So I deal with the airway. Maybe call the registrar to inform the situation. So also give her some education and prevention. So refer to the physiotherapist for breathing exercise when the SATs and everything's going back to the normal when she's settled. Also encourage the patient to take deeper breath meanwhile. Evaluation. So my prioritize will be airway first. So I'll give try to put the hyponasal on if she's able to tolerate it, and then aiming the saturation back to 92 because that's what we're aiming at. After that, I'll do breathing, make sure breathing's alright, see circulation, make sure metronom is still on, and then her blood pressure is alright. Also, and then disable and exposure. So I'll go through check the pain medication, pain wise, and also the ondansetron, so that I can give her some antiemetic. So also I done ABG in the end at end of the 12-hour shift, and then make sure what's going on, like it's getting better. So in my conclusion for the respiratory airway assessment, I use look, listen, and feel ways approaches, decrease air entry sound for this patient, and data action reaction. So data is I got this data, so saturation is dropping, so my action is thinking about what's the priority for the needs of the patient, and then do some reaction as well. Meanwhile, when by the end of the shift, the senior registrar came to visit, review the patient, so they were thinking about maybe it's a late symptoms of the COVID precaution, COVID related lung function decrease, but they haven't confirmed yet. So, but anyway, we started some precaution. Also, we try to the doctors will try to call the confirm with the consultants to make sure that we're on the right track to treat this patient. So this is all my references.